Good morning to all of you and welcome to this session on hypertension in pediatrics, causes and management. I will be focusing on a very practical based approach and will be dealing with mostly the basics so that you will be better equipped to handle a patient with hypertension in your clinic after the talk. Okay, so we will primarily be focusing on recent guidelines. As I said, practical aspects, keeping beginners in mind. What we will not be discussing today is details of individual causes of secondary hypertension, which is out of scope of a single presentation or a teaching session. Lifestyle modification for essential hypertension, we will not go into details. And if you have gone through the guidelines, you would know that there are certain aspects which need a lot of elaboration, which include ambulatory blood pressure monitoring, which actually I think is a wonderful way to assess hypertension. This is one of the non-invasive techniques which have come into clinical cardiology in a very nice way. Unfortunately, we do not have the time to go into details of that. So we won't be discussing white coat hypertension or masked hypertension, etc. in detail. And we will not also go into the data regarding home or school measurements. So what we will focus is what you are going to do in the clinic when you see a patient. So how I'm going to approach this is, one, we will be discussing a stepwise 5-question approach, which you can adapt when you're seeing a kid with hypertension in the clinic. And how we're going to understand this is by analyzing 2 clinical scenarios using these questions. All through the talk, major changes in the recent guidelines will be highlighted. So let us go to the clinical scenarios. This is the first patient. I'm sure many of you would be able to connect to this. Here is a 9-year-old girl who comes with history of some heart surgery which was done when she was a few months old. She has lost all papers, lost a follow-up, suddenly pops up in your clinic with complaint of severe headaches for 3 to 4 days. You measure her blood pressure and you find that it is 150/90 in the right arm. Now you're wondering whether to call the cardiologist or whether to send to the neurologist. So this is not an uncommon situation. Number 2, here is a 15-year-old boy. He was noted to have high blood pressure on school health screening. He is absolutely asymptomatic. He is being referred to you for further assessment. You measure his BP and you find it 136/88 in the right arm. 2 common or perceivable clinical scenarios I'm sure most of you will be able to connect. So how do we evaluate these 2 scenarios using the 5-question approach? So question number 1, does the child really have high blood pressure? Question number 2, do I have time to ask any more questions? 3, why does the child have high blood pressure? 4, what has high blood pressure already done to the child's body? And 5, what should we do about it? So let's take question number 1. Does the child have blood pressure? So how do you know? So what I would say is, in spite of all the advancements that we have in clinical medicine, blood pressure measurement, I would say, Stone Age. We have a lot of limitations, especially in pediatrics, when it comes to measuring blood pressure. So before you act on any recording, make sure that the recording is correct.
Madam, screen on the share, madam. A screen and the cut, presentation screen.
Okay. കിട്ടുന്നുണ്ടോ?
കിട്ടുന്നുണ്ട് madam. Okay, madam.
Okay, thank you. So errors can be from multiple sources. You have to use the correct cup size for the patient size. And also you have to have a look into what type of equipment is it that you are using and what are the inherent flaws associated with the equipment. Also, you should also find out actually who checked the blood pressure using not only with what machine, but who was the person who actually checked the blood pressure. Because all your further steps are going to depend on this one measurement. Yeah, and of course, crying kids, it is sometimes extremely difficult to know what exactly the BP of the child would be. But whatever it is, we are pediatricians and we need to do it. So once you get an accurate BP, the next step will be to find the percentile. So you can either use the height or the height percentile and the age, and you know how to know the percentile of the BP. So what I would like to highlight here is that the blood pressure tables have been changed in the recent guidelines of 2017 issued by the AAP. And the difference between these latest charts and the previous ones is that the latest 2017 chart includes data only from children with normal BMI. So after finding out the percentile, you have to categorize the blood pressure into any of these categories. So normal will be considered less than 90th percentile. If it is more than 90th and less than 95th percentile, you would call it elevated BP. If it is more than 95th percentile to less than 95th plus 12, you call it stage 1 hypertension. If it is more than that, you call it stage 2 hypertension. And for children more than 13 years of age, they have given the cutoffs as such, which is pretty similar to the adult values: normal, elevated BP, stage 1 hypertension, stage 2 hypertension. So stage 1 is 130 by 80 to 139 by 89. Stage 2 is more than 140 by 90. This, even for the adult hypertension guidelines, is a major change and is being debated widely as to whether we should lower the cutoff or not. But for whatever reasons, as of now, this is what the AAP guidelines say. And if you look at the long-term benefits of picking up and addressing blood pressure at an early stage, it would really mean that it might be better to pick it up and address it at even lower values than what was previously recommended. In the adult clinical hypertension scenario, there has been only one study which is focused on elderly, the very elderly, which is more than 70 years of age, which says that aggressive blood pressure control might not be as useful as in the other patients. So for all practical purposes, if you go with the mindset that you catch these patients early and treat them early, it is going to benefit them a long way with respect to target organ damage and complications thereof in the years to come. So what is the difference from the previous guideline? One, pre-hypertension, the name has been changed to elevated BP, and the percentile change is also new. It is different from the previous one. The previous one was 95th percentile to 99th plus 5 millimeters of mercury. Yeah, so this I just wanted to mention that it is pretty much similar to the adult guidelines, which is for more than 13 years of age. So I've highlighted the more than 13 years of age. And another important thing or practically helpful tool which you can find in the guidelines is that the screening values of blood pressure for every age which requires further evaluation is being given as a table. So you can actually make a cutout of it and store it on your mobile phone, or you can paste it in your clinic so that you know at what age what blood pressure needs further evaluation without like actually looking at the height or height percentile or going into the percentile charts. So this is also a new addition to the recent clinical guideline. So going back to Kanishka, so her height percentile falls in 75th. So her BP 95th percentile is 116 by 75, 95th is 128 by 87. So she is way more than all that, and she will fall into stage 2 hypertension. How about the other boy, Robin? So here his height percentile is 50th, you calculate you find out the 95th percentile and the 95th plus 12, and you know that he falls into stage 1 hypertension. So now what? Question number 2, do I have time to ask any more questions? So here what I mean to convey is that when you see high blood pressure, you have to first make sure that you are not dealing with an emergency situation which needs an ICU admission and stabilization of blood pressure. Is that what you're dealing with, or you have time to work up the kit before starting treatment? So in this aspect, we will discuss hypertensive crisis or acute severe hypertension, which as mentioned, requires ICU admission and stabilization prior to workup. So what do you mean by acute severe hypertension? It means that the patient is either symptomatic, which could be either headache or epistaxis or vertigo, visual impairment, sometimes facial palsy, seizures, maybe stroke, dyspnea, maybe chest pain, palpitation, syncope. Or if you do not have any symptoms, but the blood pressure is more than 30 millimeters of mercury above the 95th percentile, or more than 180 by 120 in an adolescent, you can directly admit the patient to ICU and stabilize the blood pressure before you start doing any further workup. So when you discuss hypertensive crisis, there are two words which you will encounter frequently. One is hypertensive emergency, one is hypertensive urgency. Generally, the term emergency, I would say, is used when there is evidence of target organ damage. That is the easiest way to remember it and do it practically or find it out practically. So when you say target organ damage, you should understand that it should be either new or progressive or worsening, like heart failure, encephalopathy, or acute renal failure. So chronic renal failure is definitely target organ damage. But if you see a patient with hypertension and chronic renal failure secondary to hypertension, if his blood pressure values are within the acceptable ranges, you do not call it hypertensive emergency naturally. So it should be either new, progressive, or worsening to call it an emergency. Yeah, so if it is a hypertensive emergency, you directly admit to ICU and manage the patient simultaneously, or in the phase of stabilization itself, you can start your work. So what do you do in the ICU? So do you give IV or oral medications? IV is generally indicated only when oral is not possible, or if you have a target organ damage which is looking at your face and warrants more controlled BP reduction. So what is your target? The short-term target should be approximately the 95th percentile, and you should not be too fast in bringing down the blood pressure. So what is recommended is to bring down approximately 25% of the planned production over the first 8 hours, with the remainder, which means 75%, you will do over the next 12 to 24 hours. Of course, there are exceptions like an acute aortic dissection or a pheochromocytoma crisis, severe. So, some of it are out of context to pediatrics, but I have mentioned it for the sake of completion. I would say that the primary scenario where you would enter an acute aortic dissection in pediatrics would be any of the syndromes, connective tissue involvement like Marfan and Marfan variants. Or you should also understand that there is a aortic medial abnormality associated with some of the congenital heart diseases like common tetralogy of Fallot, which can lead to progressive aortic dilatation even after a tetralogy of Fallot repair. And if you in a clinical setting which you could fit into acute aortic dissection, high blood pressure, then which means that excruciating chest pain and extremely high blood pressure. So in that scenario, you should definitely consider it. All right, so the patient number 1 has acute severe hypertension. So what are you going to do? You can admit her to ICU. She has headaches, of course, but you have done further evaluation and you found that there is nothing going on inside the brain other than the headaches. So you start her on oral medications, and if she's not responding, of course, you can start IV medications. So how about the other patient? No, he does not have any emergency. He has only stage 1 hypertension. So you have all the time in the world to work him up before you decide on treatment. So now comes the questions related to workup. Why does the child have high blood pressure? And for what has high blood pressure already done to the child's body? So these two you can evaluate based on a complete clinical assessment as well as some investigations. So this brings us to the causes of secondary hypertension. So I have made a point to mention mostly the most important ones, and I definitely will not be going into the details of each of these. You know that the major chunk would be either renal or cardiac. Renal could be renal parenchymal disease or structural abnormalities, reflux nephropathy, obstructive uropathy, renovascular disease, which means renal artery stenosis. Cardiac, primarily it is coarctation of aorta. Things which can be similar to coarctation includes abdominal aortic obstruction, which could be there in Takayasu disease, or some people call it middle aortic syndrome. And also the syndromic diseases where there is inherent abnormality of the blood vessels, which include Williams syndrome, Alagille syndrome, neurofibromatosis, etc. Then comes endocrine and neoplasia, and a number of conditions can be clubbed into it. Details of each of which will not be discussed in this session. And one thing which you should remember, especially in obese, overweight adolescents, is obstructive sleep apnea syndrome. This actually has been found to have a dose-response type of relationship, which means more severe the obstructive sleep apnea, the higher the blood pressure, and it needn't be directly proportional to the level of obesity. And it has been proven beyond doubt that if you treat obstructive sleep apnea, it can reduce blood pressure in adults. In children, there has not been much of an evidence, but you should keep this in mind, because when you deal with an individual patient, Abhilash, any issue there?
Going to pediatric hypertension അതല്ല മറ്റേതന്നെ എന്നാന്നറിയാമോ മൈറ്റൽ സിനോസിസിനാ ചെയ്തത് മാറ്റൽ ഡോക്ടർ പറഞ്ഞിട്ട് കാര്യമാണ് you have to listen from the first.
Abhilash, can you hear me? Am I audible?
I'm audible. No
No,
issue.
I heard a lot of noise, so I was like wondering, is there a problem? I can continue now.
Ma'am.
Okay. So yeah, so then newer stuff has also come up into the list of secondary hypertension, which means environmental exposure to some chemical compounds like lead, cadmium, mercury, phthalates, etc. Phthalate you find it everywhere in all of the things that you use daily. There are a lot of phthalates in it. We don't know the direct relation, but there has been some speculation regarding that also. So if you look at it age-wise, it is important to note that the younger the child, the higher the chance that you're dealing with secondary hypertension. 99% would be secondary hypertension in the first year of life, 70 to 85% from 1 to 12 years, and 85 to 95% between 12 to 18 years. And yes, in the first year of life, coarctation of aorta tops the list, and afterwards, renal tops the list as a cause of secondary hypertension. So younger the child and higher the BP, more chance that you would be dealing with secondary hypertension. Also, I would mention that studies from the West have highlighted the increasing prevalence of primary hypertension, which is strongly linked to childhood obesity, particularly in the adolescent population. So you have to keep that also in mind. Now, your history and clinical examination should be so thorough that we can customize lab work for each patient, because if you start doing the entire lab workup for every single hypertension patient that you encounter, that is not going to work. So what you have to do is you have to actually find out how you can customize the lab workup to the patient in front of you. The patient in front of you on clinical examination might give you some clues as to what further steps need to be done. So do not think about getting the whole set of workup for everyone. From a thorough clinical examination, reach some direction so that you can tailor the workup to each patient. So when you evaluate, you have to look for symptom signs related to individual causes of hypertension, related to hypertension itself, and target organ damage. So what can be done or what should be done for every single patient is: 1, urinalysis and culture; 2, looking for proteinuria or microalbuminuria; of course, burn and serum creatinine, electrolytes, lipid profile, fasting plasma glucose, more important if it is an older patient and you are suspecting essential hypertension, renal ultrasound, and an echocardiography. These are the things which you can get done or which you should get done for all patients. So this I have like conglomerated from my own clinical experience as well as the best points in both the guidelines that are available currently for managing pediatric hypertension. So, as I said, the red flags which warrant additional workup for hypertension would be: 1, young age at onset, and 2, resistant hypertension. So, on your clinical examination, if you hear a renal bruit, or if you think there are any syndromic features which could cause obstruction to renal arteries, then you should definitely work up for renovascular hypertension to the full extent. If you think the patient has resistant hypertension and you have symptoms of pallor, sweating, flushing, then of course you need to tailor the workup to find out endocrine causes, which includes the 24-hour urine or plasma metanephrines. And if the patient is young and has resistant hypertension, potassium abnormalities, you have to look for mineralocorticoid excess. You have to work up in that line. So this is how you should customize your clinical assessment. If you customize your lab work based on your clinical assessment. So how about primary hypertension? Generally, they are older and generally they might have a family history of hypertension and are generally obese or overweight. So if all the above criteria are met and you don't find any features of secondary hypertension in the history or clinical evaluation, extensive workup might not be necessary. You have to use your clinical judgment on a patient-to-patient basis. Now we come to point number 4. What has high blood pressure already done to the child's body, which means target organ damage. So you have to look what the blood pressure has done to the heart and blood vessels, kidneys, and the brain. So for the heart, you look at LVH, blood vessels. It is currently in the research setting, which you look for carotid intima medial thickness. But yes, you should know that these are the things which you could assess if required. Kidneys, of course, proteinuria, albuminuria. And brain, depending on the clinical presentation, you can use either an ultrasound or CT or MRI or EEG, whichever suits the clinical situation. So what else do you need to know about target organ damage? You should understand that even if the patient already has target organ damage, adequate control can lead to regression of target organ damage, including left ventricular hypertrophy, decrease in carotid intima medial thickness, and even normalization of albuminuria. So let us go back to our clinical scenarios. So the patient number 1, Tanishka, you find a thoracotomy scar. Her femoral pulses are not well felt, and you do a forelimb blood pressure findings of approximately 50 millimeters of mercury between the right arm and the lower limb. She also has a systolic murmur, which is grade 3. So what could be the possibility? She has a thoracotomy. So it could be a surgery which is done through thoracotomy, which is primarily coarctation of aorta in this setting, and likely she has developed recoarctation. So you do an echocardiogram and you confirm your clinical diagnosis. And the second patient, you ask further, there is family history of hypertension and his dad actually had myocardial infarction at the age of 45 years, so you are in the right setting for essential hypertension. He is overweight, his BMI is the 90th percentile, and of course, there is nothing else positive in clinical examination. You do a workup, you see that his fasting plasma glucose is 121, which means that he is all set up for the metabolic effects, or something similar to what you see in adults, which is related to the obesity and overweight thing. So all other baseline workup you expect, of course, to be negative in this patient, and there is no evidence of target organ damage also. So likely this patient has primary or essential hypertension. So now what should we do about it? Question number 5. So secondary hypertension, of course, treatable causes should be treated as soon as possible after initiation of appropriate pharmacotherapy. And if there is no hypertensive emergency and it is likely primary or essential hypertension, then what do you do? How do you decide on pharmacotherapy? So first question again is there target organ damage or diabetes? So if there is target organ damage or it is a known diabetic patient now developing hypertension, then there is no question of waiting. You can initiate pharmacotherapy without waiting. Otherwise, you have some time. So depending on the class, you can wait for a variable period of a week to 3 months to maybe a year to give them time for lifestyle modification, rechecking the BP, working up, and then, starting pharmacotherapy. So what would be your target when you start pharmacotherapy? You have to bring systolic as well as diastolic blood pressure to less than 90th percentile in children. So in adolescents and adults, in adolescents more than 13 years of age, it is less than 130 by 80 millimeters of mercury. And in CKD, it is recommended to be less than 50th percentile. And they are recommending to use ambulatory blood pressure monitoring in that setting, which we don't practically use. But you can keep in mind that CKD requires more aggressive reduction in blood pressure. So this again is a change from the previous recommendations. In the previous recommendations, it was the target was 95th percentile for blood pressure control in the entire spectrum of kids. Now it is changed to 90th percentile. Now coming to pharmacotherapy. So the first line pharmacotherapy agents which are recommended include either an ACE inhibitor or an angiotensin receptor blocker, which you use mostly when ACE inhibitor is not tolerated. You can use long-acting calcium channel blockers. You can use beta blockers or thiazide diuretics, depending on your clinical situation. Any of these can be used as a primary medication. You can start at a low dose range and titrate up as required. You can add a secondary medication if required, if your single drug is not controlling your blood pressure. So yes, you can start with any of these and add on any of these, and depending on what clinical situation you are dealing with. So in some particular diseases, some particular medications are preferred and some are contraindicated. I won't go into the details. The major ones include like beta blockers are contraindicated in bronchial asthma. And if you have bilateral renal artery stenosis, you are not supposed to give ACE inhibitors or ARBs. These are the major red flags. And then if there is chronic renal failure, you generally do not use potassium-sparing diuretics. So what do you advise the patients? Robin, the boy 15-year-old with stage 1 hypertension, you advise him lifestyle modification, which essentially means exercise and diet. You recheck blood pressure and the fasting plasma glucose, and if you find he's still in stage 1, then you can start any of the medication. I would actually prefer an ACE inhibitor for him, given his metabolic setup. And for the other girl, Talishka, you can, after controlling her blood pressure in the ICU, you can develop a long-term medication for her. But of course, because she has a significant recoagulation, she will require address of her, the underlying disease which has led her to present with hypertension. So yes, ambulatory blood pressure monitoring, as I said, ambulatory blood pressure monitoring is an important aspect of blood pressure monitoring. And as I was Googling, what are the newest stuff into blood pressure monitoring, I came across this interesting concept So there is this concept of, this is not purely medical. I'm just presenting it for the interest, for my own interest in technology. So so there are things which people are trying to bring up, like tech tattoos. You have enrolled or impregnated into tattoos which can monitor what is going on in your body, like even temperature, and it can even sense your heart rate and blood pressure at times, and it can be connected to a server, and you can get updates on your mobile phone from these tech tattoos. I found it very fascinating. I'm just mentioning that there is no limit to how technology can evolve to help us. Yeah, so I see it can send messages like, your kid's BP is too high and send him to hospital, else he can develop heart failure, stroke, or kidney failure. But practically how much ever advances come in, it ultimately depends on what your patients take. They may not take it very well, and I'm sure most probably if in most of the people get a message like this, they will be asking, "Vere prashna onnu illallo." Anyways, so thank you so much for your patient listening, and I'm happy to take any questions if any of you have anything for discussion. Questions? Abhilash, am I still audible?
audible ആണ്.
Okay.
മാഡം ഇങ്ങനെ ആണോ? ഓക്കെ എന്താ ഒരു ക്വസ്റ്റ്യൻ മേഡം GMCH കൊല്ലം ഒരു ക്വസ്റ്റ്യൻ ചോദിച്ചിട്ടുണ്ട് മേഡം, ഒന്ന് നോക്കാം മേഡം ചാറ്റ് ബോക്സിലെ.
ചാറ്റ് ബോക്സിലോ?
ആ
അതെ, എവിടുന്ന് ഞാൻ എസ്കേപ്പ് അടിക്കട്ടെ ഇതിന്ന്?
വേണ്ട, റൈറ്റ് സൈഡിൽ തന്നെ മേഡത്തിന് കാണാൻ പറ്റുമല്ലോ ചാറ്റ് ബോക്സ്.
എനിക്ക് കാണാൻ വയ്യല്ലോ. അഭിലാഷ്, എവിടെയാണെന്ന് എനിക്ക് ഈ ഒരു കോളം മാത്രമേ വരുന്നുള്ളൂ കുറെ വീഡിയോസുമായിട്ട്.
മേഡം ഒന്ന് ഷെയറിൽ പോയിട്ടാ മേഡം, ഷെയർ മൈ മീറ്റിംഗ് വിൻഡോ കൊടുക്കാവോ? ഷെയർ മൈ മീറ്റിംഗ് വിൻഡോ.
You are sharing keynote video, mute me, pause.
മേഡം ഷെയറിൽ പോയോ മേഡം ഒന്ന്?
Share my meeting window.
മീറ്റിംഗ് വിൻഡോ
ആ.
റൈറ്റ് സൈഡിൽ കണ്ടായിരുന്നു മേഡം ചാറ്റ് എന്ന് പറഞ്ഞ് കിടക്കുന്നത്?
ചാറ്റ് കണ്ടു, പക്ഷെ അതിനകത്ത് ക്വസ്റ്റ്യൻ കാണാൻ വയ്യല്ലോ.
താഴോട്ട് സ്ക്രോൾ ചെയ്ത മേഡം, അതന്നെ താഴോട്ട് ആക്കി.
During follow-up of a secondary. So here is a question. During follow-up of a secondary hypertension, at what level of BP should we start? Is it above 90th percentile? Follow-up of secondary hypertension, example glomerulonephritis, above what level of BP should we start treatment? Is it above 90th percentile? So diagnosis, there is no difference. Diagnosis, you can follow the same, but on follow-up you should aim lesser percentiles. So 90th percentile is a target for 90th percentile is a target for general public. I mean, sorry, not general public, the general patients with hypertension. If you have chronic kidney disease, what is recommended is 50th percentile, 50th, not even 90th, 50th percentile, but the recommendation is from ambulatory blood pressure monitoring. So you have to keep that in mind. Any other question?
Ma'am, one more question from MCH Alapi.
Yeah, please go ahead.
Ma'am, there is a question in the chat box.
Are oscillometric methods still the standard for the? So that is what sorry, the question is, are oscillometric methods still the standard for BP measurement? Unfortunately, what I would say is that is what I mentioned. We are still in Stone Age here because we only have, two, essentially practically two methods to look at blood pressure. One is either use it with the conventional cuff and a mercury manometer, which I don't know how many of you are aware that mercury is currently being eliminated from hospitals. So we might stop getting them in a while, and we will be left with only the oscillometric NIBP cuffs, which I am generally not happy with. And if I have to make a decision on a critically a problematic patient, or if I face a clinical situation where I am in dilemma as to what to do, I would rather measure the blood pressure on my own using the old mercury blood pressure measuring equipment, not the NIBP one. But practically for routine use, we all use the NIBP ones, which is oscillometric. Yeah. And the gold standard is invasive arterial blood pressure monitoring, which you just can't do for every patient. Even in your ICU, unless you are in a well-equipped and ICU where you are used to doing arterial blood pressure monitoring, it's difficult. So one more question: when do we decide on when to start a second drug for blood pressure control? So that is something. So the question is, when do we decide to start a second drug for blood pressure control? So that, I would say, will depend on the stage of hypertension. If it is stage 1, I would go slow, and if it is stage 2, I would go faster. And generally, I would give at least 2 to 4 weeks on one drug, because you at least see them weekly and slowly go up on dose. So you start with the lowest dose possible. Sometimes you don't start with the lowest dose. Depending on the blood pressure, you use your clinical instinct and start a decent dose, not of course the highest dose, and then you slowly go up, at least weekly monitoring. And if you see that you've reached the highest dose possible of the single drug, and you've given at least a week or two for the highest dose to act, still you are not getting the expected response, then you can use a second drug. Yeah, so I see one more question. How will you rule out white coat hypertension in children? So that is what I mentioned in the beginning itself. Like, there are certain things which are not pretty clear in the pediatric area. One is white coat hypertension, which means that in the hospital or clinic setting, you get high blood pressures. But if you measure it at home or at school, school might be, not a proper setting. But at home, you will get a normal blood pressure. That is what you mean by white coat hypertension, which means that the blood pressure goes up when they see a white coat. That means in a healthcare setting. So one way to assess this is ambulatory blood pressure monitoring, which unfortunately is not widely used in India. It is an excellent method of finding out what is happening to a patient's blood pressure and targeting and starting as well as adjusting therapy. So that is one way to find out whether there is white coat hypertension, but I'm sure it is not going to be as much of a clinical problem in pediatrics compared to adolescent or adult population. And there is one more question. What is this is nothing to be worried about when you are discussing. So sorry, the question is, what is peripheral accentuation of blood pressure? So this is nothing to be worried about when dealing with systemic hypertension in pediatrics or adults in your clinical setting. Peripheral accentuation of blood pressure only means that the blood pressure that you measure in the smaller blood vessels in the periphery, radial or femoral, would be higher than what you would measure in the aorta. So that is because of elastic recoil and it involves physics and the elastic recoil of the blood vessels, and this is nothing to be concerned, or this is nothing to be considered into account when treating or diagnosing or treating hypertension. Any other questions?
Ma'am, one more question from MCA Chalapi.
Mm-hmm. Yeah, go ahead. Let me see. 1 minute. I see one for second drug that we already addressed. One is peripheral accentuation of blood pressure that we already addressed. That's all that I see. Oscillometric methods we answered. No, I don't see any other question. Up to what level of creatinine we can use ACE inhibitor? Is that the question? That is column. Up to what level of creatinine we can use ACE inhibitor? So this depends on what setting you are using the medication. So I will tell you one setting where you have a patient with high blood pressure presenting with acute renal failure. So this is first presentation, acute renal failure. You are dealing with the patient for the first time, or the patient is in the medical setting for the first time. Here, I will not start ACE inhibitor if there is any level of creatinine. So here, I would rather use drugs which will not affect the kidney, stabilize on whatever other drugs. But if you're dealing with a chronic renal failure patient, ideally, any level of creatinine, you can start ACE inhibitor, because ACE inhibitors and ARBs in chronic kidney disease have a renoprotective effect. But what you need to monitor is, once you start, you repeat your urea and creatinine in 2 to 3 days, 48 to 72 hours. Look where the creatinine is going. If it is increasing by more than 20% of the baseline, then you should stop and do not give it. If there is either no increase, or if it is less than 20% of the baseline, then of course you can continue at a decent dose. Other point when you deal or when you use ACE inhibitors and ARBs in renal failure setting is monitor potassium. Potassium hyperkalemia can kill your patient, so monitor it.
Ma'am, regarding addition of a second drug for hypertension, how do we decide which drugs to start on? Okay.
Which drug to start on will depend on the scenario. Generally, it is so. If you've started an ACE, generally how I do is, if you've started an ACE inhibitor, my first choice of drug, it varies depending on what setting you're dealing with. If I have a post-coagulation repair baby with hypertension, I prefer beta blockers. If I have an essential hypertension patient, an adolescent, I would prefer ACE inhibitors. If I have an adolescent or essential hypertension kid who has a contraindication to ACE inhibitors, I would prefer calcium channel blocker. So the second drug will depend on what was your first drug and what level of BP control you have reached. A good combination includes any of these with a diuretic, like ACE inhibitor plus diuretic, like it's thiazide, or CCB plus thiazide, or beta blocker plus thiazide. Some people say that they should not be combined. In pediatrics, you generally don't come to that setting where post a beta blocker with the thiazide. So that is not in our scope of discussion.
Any other questions?
wind up then?
Okay, ma'am.
Okay, thank you so much.
Thank you, ma'am, and thank you all the institutions